years or so now. Subspecialty interest in hip and knee replacement, and is currently completing a PhD on the influence of obesity on knee replacement outcomes in Australia. Chris, an Assistant Deputy Registry Clinical Director for the Australian Orthopaedic Association National Joint Replacement Registry, and has recently been appointed as the Orthopedic Surgery Co-Chair for the Australian and New Zealand hip fracture industry. And as such, is in a fantastic position to tell us all we want to know about fractured hips. So over to you, Chris.
Brilliant. Thank you very much, Philip, and good evening, everyone. Just give me 2 seconds while I share my screen. Can everyone see that and hear me okay? Yep, great, thank you. So good evening and greetings from Toowoomba in southeast Queensland. I'd like to thank the College of Surgeons and the Victorian Audit of Surgical Mortality for hosting this webinar. And to start this evening's discussion, I'd like to present a brief overview of the ANZ Hip Fracture Registry and review some of the results from the 2023 annual report. Here are my declarations of interest. So the ANZ Hip Fracture Registry is a clinical quality registry that collects data about older people admitted to hospital with a broken hip in Australia and New Zealand. The registry is managed by a group of clinicians with representation from key professional organisations. The registry is designed to allow hospitals to audit the care they provide against key markers of safe, high-quality care. The data can then be used to improve clinical performance, examine national trends, advocate for better clinical care, and ultimately to optimise patient outcomes. Since registry inception in 2015, data for over 105,000 hip fractures have been collected, and over 100 hospitals across Australia and New Zealand have contributed data. In 2022, data from more than 16,000 hip fracture patients across Australia and New Zealand were included. Here's a breakdown of the public hospitals in Australia that contribute data. And as you can see, 15 of the 20 eligible public hospitals in Victoria contribute, and we'd love that number to be 100%. A small number of Australian private hospitals also contribute data, and we're very keen to increase that number as well. In Australia, in 2022, over 13,000 hip fractures were reported to the registry. And to give you a bit of an idea of the demographic of patients included, the mean age was 82 years and 2/3 were female. 73% lived at home prior to their hip fracture, and 38% had some degree of cognitive impairment prior to their injury. 44% of patients were independently mobile prior to breaking their hip. As many of you know, the Australian Commission on Safety and Quality in Healthcare has a series of clinical care standards, one of which covers hip fracture care. The ANZ Hip Fracture Registry reports on care for 16 indicators across the 7 quality statements in the Hip Fracture Clinical Care Standard, which are care at presentation, preoperative pain management, having an orthogeriatric model of care, timing of surgery, mobilisation and weight bearing post-operatively, minimising the risk of another fracture, and finally transition from hospital care. So this is a snapshot of results from the 2023 annual report along the patient journey from admission to discharge. Green dots represent areas where care has improved from the previous year. Orange dots represent areas where there's been no change. And red dots represent areas where there has been a decline in performance. Now, my orthogeriatric and anaesthetic colleagues will discuss some of these performance indicators in their talks later on. But from a surgical point of view, I'd like to focus briefly on time to surgery. A key concern for us as surgeons is that only 78% of patients had their surgery within 48 hours of their first presentation, which is less than previous years. In Australia, the mean time to surgery for non-transferred patients was 38 hours, and the mean time for transferred patients was 51 hours. And both of these figures have increased from previous years. The main reasons for delay reported to the registry are lack of theatre availability, the patient being medically unfit, and the patient being anticoagulated. Now, Hass is going to talk about medical reasons for delaying surgery in her presentation a bit later. And Ben's going to discuss anticoagulation from an anaesthetic point of view. But there is some good news on the anticoagulation front from a surgical point of view, which I'll discuss in a minute. Some of you may be aware that an updated hip fracture clinical care standard was published late last year. And one of the key changes is that patients should now be operated on within 36 hours of first presentation to hospital, as this has been shown to reduce 30-day and 1-year mortality. Last year in Australia, just over 50% of patients achieved this target. So for all of us who are involved with hip fracture care, it's really important that we engage with our hospitals and health services to ensure that our patients receive appropriate and timely surgery. And a key challenge for those of us working in regional centres is that up to 50% of our patients are transferred from peripheral hospitals, and the clock starts ticking at the time of presentation to the initial hospital. So in Toowoomba, we've addressed this by prioritising same-day transfer with the Royal Flying Doctor Service and the Queensland Ambulance Service. And then we up-categorise patients' priority on the emergency board at 8 AM on the day after their initial presentation. Now, unfortunately, this hasn't solved the problem, but we're doing our best. The Fragility Fracture Network has just published an international consensus statement on timing of surgery for patients on direct oral anticoagulants. And it states that hip fracture surgery can reasonably be performed within 36 hours of the last DOAC dose. So from a surgical point of view, we can advocate that patients on DOACs shouldn't have their surgery delayed. And I'll let Ben discuss timing of anaesthesia for patients on DOACs a bit later this evening. Each year, the ANZ Hip Fracture Registry conducts a sprint audit focusing on a specific topic related to hip fracture care. In the past, we've looked at nutrition, bone protection medication, and acute rehabilitation. And this year, we're going to be focusing on DOACs. In last year's sprint audit, we looked at preoperative fasting. Data was collected for 516 patients from 33 sites. And disturbingly, nearly a third of patients had been fasted more than once. The median fasting time for solids was 12 hours, with a range up to 54 hours. And the median fasting time for fluid was 10 hours, with one poor patient having nothing to drink for 50 hours. And clearly this is not ideal. There's a new initiative called Sit Till Send, which hopefully will address this issue. And I think Ben's going to discuss this in a bit more detail shortly. So in closing, the ANZ Hip Fracture Registry would like to thank everyone involved with hip fracture care in Australia and New Zealand. And I'd personally like to thank Jackie Close, the Geriatric Medicine Co-Chair, Kath McDougall, who many of you will know, she's the former Orthopaedic Surgery Co-Chair, and finally Jamie Hallen, who really is the heartbeat of the registry. Finally, we're holding Hip Fest in Sydney in November later this year, and we'd be delighted to see you there. So please jump on the website to register. Thanks very much.
Thanks very much, Chris. That was fascinating. And please remember, everybody, if you want any questions for the end of the session, put them in the chat or get in touch with us through some other sort of way. I don't really think we can have people just sort of yelling out and asking questions. It won't work. To talk about some of the surgical aspects now of these operations, we've got Associate Professor Raphael Howe. Raphael obtained his fellowship about 10 years ago now and completed a trauma fellowship at the Austin, followed by an arthroplasty fellowship in Bristol and in Vancouver, Canada. He's a founding steering committee of the Australian New Zealand Hip Fracture Registry. He's also clinical director of orthopedics at Eastern Health and is an adjunct associate professor at Monash University and an honorary associate professor at Melbourne University. So over to you.
Thanks, Philip. I've been given some very interesting data from VASM, and I'm going to present some of those and mix in a few slices from the hip fracture registry to bring interest. So I've chosen to present the data from VASM from 2022 because the 2023 data is still sort of under review, and a lot of cases wouldn't have had their first line assessment yet. So from 2022, we had 826 orthopedic VASM cases, and 64% of them involved patients with a hip fracture. So a large chunk of orthopedic deaths in patients in a hospital had to do with hip fracture patients. In terms of gender, just over half of these hip fracture cases were female. As we heard from Chris, 66% of hip fracture patients were female, and that's sort of offset by a much higher likelihood of male patients succumbing to death. So 54% of patients are female in the hip fracture group, and 44% are female in the non-hip fracture orthopedic group. Can we work out the mortality rate from these 529 hip fracture VASM cases? Well, we need to know the denominator for that in Victoria. And the short answer is not hard. It's not easy to find. The National Hip Fracture Registry reported about 2,500 patients from various hospitals. And if we plug that in, that will work out a staggering 21% inpatient mortality. But that's probably overestimated because, as Chris said, there are still a number of hospitals in Victoria that are not contributing to the national data. So short answer is we're only guessing what the inpatient mortality is like in Victoria from those hospitals that contribute to the national data. You already saw that. So this is a chart from a couple of years ago from a national registry. So we are down here, Victoria. So 2021, the 30-day mortality for hip fracture patients is 9.4. So we are really highest in all the states and also compared to New Zealand as well. So in 2021, we're lagging behind. Similar for the 1 year mortality. So 24% in 1 year, and this is data from 2020. Interestingly, New Zealand had a higher mortality rate than Victoria. So out of that 529 VASM cases, 91% of the patients had an operation and 9% didn't have an operation. So this is the patients who didn't have surgery was overrepresented in the mortality group, which makes sense because we expect a lot of the patients who are too frail to have surgery will end up not having surgery. The last year's hip fracture registry data reported 2% non-operative treatment in Australia, and we don't have any Victorian state data. So this is more granular data from VASM. So we're looking at the two groups of patients who one group who didn't have surgery and the other one who had surgery, and how long it take them for them to succumb. So obviously there's significant selection bias. Sorry, the light just went off. Yeah. So for those who didn't have surgery, almost 70% of the patients succumbed within the first 4 days. But if you had surgery, then you're much more likely to survive past 5 days. So the ratio is reversed, which makes sense because the ones who are most frail would be likely the ones who are treated non-operatively. So in the hip fracture group, only 2% of the cases went on to have a second line assessment because the first line assessment first line assessor thought that there was an issue, whereas for the orthopedic non-hip fracture group, that ratio is a lot higher, so 12% versus 2%. The VASM process also identifies clinical management issues. I think these are identified in the by the first line assessor or the second line assessors. And in the hip fracture group, 11% of the cases did have clinical management issues. Now, each of these cases may have more than one issues. In fact, among the 56 cases, there were, I think, just over 100 issues identified. So on average, each case will have 2 clinical management issues identified. And that compares to non-hip fracture cases where there are almost double as many cases having clinical management issues. So I was given a spreadsheet of, there were like 50 different clinical management issues, but I've chosen just the top few. So these issues were identified among 56 hip fracture patients and 59 non-hip fracture patients, and a smattering of issues, but most commonly delay to surgery and decision to operate, and whether, you know, the decision to operate in a hip fracture patients who are very frail, you know, would have been appropriate. And then there was some delay in transfer and medical assessment also feature in clinical management issues. So there are a few sort of themes. Hip fractures features significantly in the orthopedic VASM cases. Very small percentage will need a second line assessment, and then even few of them compared to the non-hip fracture patients had clinical management issues. So that's all I have.
Thank you very much for that. It's all very interesting data, and we'll be hopefully discussing in a bit more detail later on. Moving on now to the very important part, I think, of what's been a really great development in orthopedics in particular, is the orthogeriatric care of the hip fracture. And for that, we have Dr. Hasanka Ratnayaka, who is from the Alfred. So Hasanka is dual-trained general physician and geriatrician who leads the orthogeriatric service at Alfred, and passionate about delivering quality care for older people in both hospital and community settings. And has a particular interest in perioperative care, falls, and bone health in older people. She has a diploma of the perioperative medicine from the Australian and New Zealand College of Anaesthetists, and is a member of the Safer Care Victoria's hip fracture community of practice. She's also been involved in teaching for the Monash University Perioperative Medicine short course. So over to you.
Thank you. I hope everyone can hear me. All right, so good evening, everyone. Thanks very much for asking me to speak on this panel tonight. As introduced, my name is Hussain Kar. I run the Ortho Geriatric Service at the Alfred. So this was my first time being asked to speak to a group of primarily surgeons on this topic of ortho geriatric care. So in an effort to try to make it relevant for everyone, I asked my orthopaedic friends what they would most like addressed when talking about care of the hip fracture patient from a physician perspective. These were the themes that repeatedly came up, which I thought were quite useful to frame my talk. So when I would suggest delaying surgery, when I would suggest proceeding to palliation and non-op management of a hip fracture patient, and how to reduce the deaths post-op, which is pretty an apt question for a VASM webinar. And look, I can't provide you with a definitive plan for patients to all survive post-op, but I hope I can give you an idea of what constitutes some of the best standard hip fracture care. And I think if we can provide that for our patients, then we can be proud of the job that we've done, irrespective of the mortality outcomes, which we do know to be high in this group, as Raf also just presented. I hope I'm not being too repetitive with Chris's slides, but just to clearly outline, because I referenced these repeatedly in my talk, these committees. So the Hip Fracture Healthcare Commission, set the hip fracture care standards, of which there are 7, and these were updated last year, as Chris also stated. And I'll be providing some of the key updates in this talk. The Australian New Zealand Hip Fracture Registry is an excellent opt-in database that we can join to monitor how well we are adhering to these standards by submitting patient-level data. And this is then produced in the annual report and allows us to benchmark ourselves against state and national averages. So I highly recommend anyone interested in hip fracture care read this report when it comes out every year. So as discussed earlier, there are 7 hip fracture care standards covering patient admission to discharge. As you can see, timely diagnosis, pain management, early surgery, mobilising on the first day, minimising risk of another fracture. I won't, unfortunately, be able to discuss them all tonight because that would take way too long, but I'm instead focusing on the key changes that were made in 2023 relevant to orthogeriatric care. Firstly, each standard now has a cultural safety and equity substandard for both clinicians and healthcare services, which helps to address some of the specific care needs that arise for our First Nations patients and patients from culturally and linguistically diverse backgrounds. And the other main changes are now care of presentation. So now, in addition to diagnosis and imaging and timely management, pain management, it also includes assessing nutrition, delirium and frailty. The recommendation that all hip fractures now be considered for nerve blocks, which aligns us now with the NICE guidelines. And very importantly, as mentioned to many stakeholders here tonight, the change of time to surgery to 36 hours from previously 48 hours, which also aligns us now with the NICE guidelines. So the first change, the addition of nutrition. Why was this important? Well, nutrition was often overlooked, and a sprint audit done by the Hip Fracture Registry in 2021 showed that we were only screening about 69% of our patients, and despite the screening, often patients were not having supplements or a plan, even if they were identified as high risk or malnourished. Malnutrition is associated with inpatient falls and pressure injuries, and oral nutritional supplementation has been shown to reduce hospital complications in hip fracture patients. So practically speaking, how should we implement, or how do we implement this standard? Well, we screen everyone. We use the M&A short form at the Alfred, but each hospital would have their preferred tool from the dietetics department. And I put everyone on a high energy, high protein diet. We try to reduce their fasting period as much as possible. And we put everyone on a food record chart to document how much they are or aren't eating in the hospital. And any patient who is malnourished on screening or has poor intake in the hospital, we refer to our dietetics. There is an argument that all of our hip fracture patients should be ideally seen by a dietitian, but that's not logistically possible for many health services, including our own, unfortunately. So delirium, the addition of delirium, well, by now we know the bad outcomes that are associated with delirium: higher in-hospital mortality, higher longer-term mortality, prolonged hospital stay, more likely to be discharged to a nursing home. And it's also important, I think, that not only do we screen for patients who do have delirium when we see them in the emergency department so that we can implement care, it's also important to assess those at high risk for developing delirium, such as those with known cognitive impairment, because non-pharmacological interventions can decrease the incidence. It's also not always a self-limiting transient process. It often persists at discharge. So it's important not only to diagnose for our care, but also to set expectations for the family early. but this may not resolve in the acute hospital admission. And there's also a growing body of evidence linking an episode of hospital delirium to later being diagnosed with dementia. Of course, we can't call causality of that yet, but it's important to note for ongoing monitoring of these patients. To screen for it, and there are multiple different tools like the 3D CAM, but in my health service, we use the 4AT, which is very simple, takes a few minutes to administer at the bedside and looks at alertness, orientation, fluctuation. And then once we diagnose it, of course, we can do delirium investigations and correct or treat whatever we find. And then it's really about minimising the hospital-related harms that can come from delirium, such as falls, malnutrition, uncontrolled pain. We try to reduce the anticholinergic burden of many of the medications and polypharmacy that our patients often suffer. And I consent for the use of antipsychotics for agitated delirium early, for the simple reason that many of the atypical antipsychotics do carry an FDA black box warning for an increase in stroke and death in patients with dementia. It's one of the first things that families Google when they see these medications, and you don't want to be caught on the back foot for families thinking you've prescribed something potentially dangerous without ever having discussed it with them. So finally, the assessment of frailty is the final change for standard 1. Again, we know that frail patients do worse. We use the clinical frailty scale, which many of you may already be familiar with. It's very easy to use and assess patients when they're admitted. It helps us to explain risk to family, and it helps us, I think, most importantly, to easily paint a picture for other specialties, so that about a patient that's more valuable than just age and comorbidities and where they live. And it really helps to facilitate shared decision-making discussions and tailor our care to what is essentially a very vulnerable patient in the hospital. So that quickly covers care at presentation. I won't cover the nerve block recommendations. That's an anaesthetic area of expertise. So the next big change is time to surgery, which is now 36 hours. And as Chris did mention, our time to theatre in 2022 had actually increased from the year before. So this may prove to be quite a difficult target for this year. And we look, and as Chris also mentioned before, as we look at the reasons for delay to theatre, aside from theatre availability, the next biggest contributor in Australia was being deemed medically unfit, which leads nicely to the next question posed by my orthopaedic friends about when I would consider delayed theatre and when I think it would be reasonable. So when do I delay surgery for medical reasons? Well, knowing what we do about the benefits to timely surgery, myself and I think everyone involved try very hard not to. Instead of listing all the different scenarios for such a short talk, I'll just show you a guideline from the Anaesthetic Association of Great Britain and Ireland, which I think nicely outlines what I myself would consider reasonable for delaying theatre. So severe anemia, severe electrolyte derangement, DKA, new left or uncontrolled left ventricular failure or new, which is often precipitated by an ischemic event in our patient cohort, and uncontrolled cardiac arrhythmia, sepsis, or a reversible coagulopathy. I do take note that waiting for an echo is not considered a reason to delay theatre, which obviously is easy for me to say. I'm not the anaesthetist, but my understanding is that we proceed assuming a patient has moderate to severe AS if you can hear a systolic murmur, knowing the age and most likely pathology for our cohort, so to proceed as such. And when we review our patients in ED as early as we can, we try to cover all of these domains listed and optimise everything we can to ensure the patient can have timely surgery. A special note on the SLGP2 inhibitors, empagliflozin and dapagliflozin, which many of our patients may be on. The Australian Diabetic Service recommends this drug be ceased 2 days prior, and then on the day of surgery, we obviously don't have that luxury with hip fracture patients. So I withhold on admission and check ketones and usually get endo advice and try very hard not to delay their theatre, offset with the risk of them developing euglycemic ketoacidosis. So if we see a patient and they're looking very frail or very unwell, when would we, instead of just delaying surgery, choose a non-operative management? And as Raf noted, we're only talking about a small number of patients. 98% of our hip fracture patients proceeded to surgery. Of course, it's a very sensitive topic, knowing that if we don't operate, it is often death within days or weeks. So our focus should always be on making it a patient-centred conversation and shared decision-making process with our surgical, anaesthetic and palliative care colleagues, and of course, taking into consideration a patient's stated goals of care. So look, it's a very difficult question to answer. I don't have set indicators where I would say we absolutely don't operate. We take it on a case-by-case basis. but we know that optimal pain relief comes from fixing the hip. So choosing a non-operative approach needs to be a really well-considered and well-consented plan. And I'm myself, to reveal my own bias, unless I'm very certain the patient appears to be terminal and I'm confident they'll die today or not survive the surgery, I usually recommend surgery as a palliative pain relief procedure. As an aside, the Nottingham Hip Fracture Score is an excellent tool to discuss with families who may want to know precise percentages of 30-day mortality risk. If they want to know figures in big conversations, I often do use this. There has been some literature in this space that might help us guide the conversation and maybe influence our practice. And the studies that come to mind are the frail hip, which many of you may be familiar with. It was published in JAMA Surgery not too long ago, and an older study looking at ASA grade and mortality rates using data from the UK hip fracture database. Frail hip was a prospective study from the Netherlands that looked at frail nursing home patients and excluding those who had subtrochanteric pathological or periprosthetic fractures. And their primary outcome was self-reported, or rather carer-reported quality of life outcomes, with secondary outcomes looking at pain, morphine use and satisfaction with the dying process. This study found that it was non-inferior in non-op groups. The quality of life and the satisfaction with dying was similar between the two groups also. So their conclusion was that in a select group of very frail patients, non-operative management was not inferior to operative management with regards to quality of life. To be honest, this study hasn't influenced my personal practice. I'm not convinced that non-operative pain was acceptable. Obviously, the pain scores were always higher in the non-op group, but 2 patients were switched from non-operative to operative management due to uncontrolled pain. And also in the first 2 weeks, there was no statistically significant difference in the use of morphine in the non-op group between those who reported pain and those who didn't. So I'm wondering if some of the pain was undertreated. And the median time to death in the non-op group was 7 days. So it's not a small amount of time to be dealing with uncontrolled pain. So overall, I still have reservations about effective pain control in non-operative management, even if in this study, proxies and caregivers were satisfied with quality of life. And the second study, which provides another perspective, is this study published in Anaesthesia in 2017, which looked at death rates and ASA grade using the UK hip fracture data, and it looked and confirmed the high relative mortality rates with higher ASA grades compared to ASA 1 and 2, but the absolute mortality rates were quite good, only about under 2%. So they found 93% of ASA 4 patients survived through post-op days, and 93% of ASA 5, which is described as obviously a moribund patient not expected to survive 24 hours, survived beyond 2 post-op days. So their conclusion was that even the most frail and unwell patients largely survived the days after surgery, and this would help manage their pain, so they should be considered. And to reveal my personal bias, I tend to fall into this category of thinking. And I thought the authors of this paper put it beautifully when they said we must not underestimate the benefit of surgery, even for dying patients, which can allow them to spend their final days in comfort and dignity. So I tend to push for operative management as a palliative procedure, essentially to achieve pain control. So in my last minute, I thought I would just mention standard 6, which is minimising risk of another fracture. And these recommendations haven't changed. Everyone should get a falls assessment and be considered for anti-resorptive prescription. But actually getting these medications remains an area of improvement for all of us. Year on year in Victoria, it does improve, as you can see on the data there, but it's still under 30%. And when we started looking at our data at the Alfred, when we first joined the registry in 2019, it was 7%. We've come up now to 60% with a lot of work from a lot of people, but overall it remains an area we can all do better in. It's really important we consider bisphosphonates or Prolia in these patients. We'll never be able to stop them falling, but we can reduce further fractures with these medications with a really good number needed to treat. And a quick mention finally is some of you may have heard of this new drug, romosozumab, which is a sclerostin monoclonal antibody, a monthly injection, which is now on the PBS for severe established osteoporosis. So patients who've been on another anti-resorptive therapy for over 12 months and have still fractured with a poor bone mineral density. And this is a trial in the Lancet which headed it against teriparatide and showed increases in bone mineral density after a year of therapy that we didn't see in teriparatide. So I think we will be seeing more and more patients on this medication. However, it is contraindicated in previous MI or stroke patients. but we should definitely be considering at least a bisphosphonate or Prolia for all of our patients. So that is my quick tour of hip fracture care from a geriatrician's perspective. I hope it's been somewhat informative. So, and thank you for attending and listening this evening.
Thanks so much. That was brilliant. It's really nice to have a sort of non-surgical view and surgical meetings. To continue on that theme, we now have Ben Slater, who is an anaesthetist, works at St. Vincent's, where he also chairs the Hospital Transfusion Committee. Main areas of clinical specialisation are anaesthesia for cardiac and thoracic surgery and pain medicine. Ben is a member of the Victorian Perioperative Consultative Council and chair of the anaesthetic subcommittee. So over to you, Ben.
Thank you very much. Are my slides showing it correctly? Excellent. Good evening, everyone. Thanks very much for the introduction. Thanks very much for the invitation. I'm going to try and fly through this so that we've got plenty of time for discussion. I'm going to talk about pain assessment and analgesia, patient optimization for surgery. A lot of that I'll be able to skip over because it's been covered already. And then we'll talk a little bit about the type of anesthesia that the patients have. So pain is defined by the International Association for the Study of Pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And that's just a mouthful, but it's a very, it's kind of intellectual way of saying pain does not equal nociception. So it's not the pain that a patient has is not just a simple pathway from the periphery to the brain. Pain is nociception plus the attributed pain, and that attributed meaning of the pain, and that comes from the patient's situation and the learning they've had throughout their entire life. And pain is unique to any individual and can only be conveyed verbally and through behaviour. There is no such thing as a painometer. We can't just put something on a patient's head and go, he's got 5 out of 10 or he's got 7 out of 10 pain. It really is only through patient report that we get this information. Margot McCaffrey was a nurse who famously said, pain is whatever the experiencing person says it is, existing whenever and wherever the person says it does. And it's just a reminder that we have to take people's reports of pain very seriously, even if we don't think necessarily that their pain, their reports of pain reflect what they think they have, what they think it should be. There's sort of a myth out there that the elderly have less pain. If you carefully go through the acute pain management guidelines from the College of Anaesthetists, they rebut this. The elderly don't have less pain. They may communicate about their pain less, but as a whole, as a group, their burden of pain is the highest. And of course, they may not be able to communicate about their pain eloquently if they have delirium or dementia. And pain, of course, is a cause of delirium, and then delirium makes you less likely to be able to communicate pain, and this can lead to a spiral in and of itself. So how do we assess pain? Well, I think the most appropriate and most important way of assessing pain is looking at functional activity of the patient. Just really very simply asking the question, can the patient do what they need to do to get better? But more commonly, we use pain scores. And this might be just asking the patient to report their score on a scale from 0 of no pain to 10, the worst pain you can imagine. Or it might be using a slider to report the same thing between 0 and 10. Or in children, and maybe even some adults, using this kind of Wong-Baker face pain scale as an alternative. In the hip fracture population, we may have a large number of patients who have significant dementia or delirium. And in those, we need specific pain scales, which are observational. And there's a whole range of these that are available. But one example is the one I put up here. So the pain ad assessment tool, which just takes a number of behaviors and uses those to rate a patient's potential pain/discomfort. And we shouldn't underestimate the role of carers and family here as well in being able to provide information, important information. So once we've assessed the patient's pain, we need to know what the goals are of analgesia. What are we trying to do? And I've got as a tiny little asterisk down the bottom there, our goal is not 0 out of 10 pain. It would be beautiful if it was. But when we have that as our goal, more often than not, we're just going to give the patient other problems, so side effects of medications, itch, sedation, nausea, for example. So the first thing is that we don't want our patient to be suffering, okay? And you can have pain without suffering, and you can suffer without pain. It's obviously a much bigger obviously a much bigger concept, but we don't want our patient to be suffering from the pain we have. And we don't want it to be causing the pain directly to be causing them anxiety. Then we want to see, can the patient participate in the activities that are required to optimize their health? So can they do the deep breathing and coughing exercises that they need to do? Can they move around in bed comfortably as allowed? And can they participate in nursing and physiotherapy as they're required? And if they can do those things and they have a little bit of pain that they're not distressed by, I think then we can consider that our job in providing analgesia has been well done. So we talked about nerve blocks already, and how multiple international guidelines recommend nerve blocks for patients. Well, the traditional nerve block that's been offered to hip fracture patients has been the fascia iliaca block. It's performed by finding a point about 1 inch below the inguinal ligament at the junction of its lateral third and proximal and medial 2/3. And then traditionally this was just done with a bluntish needle and going down and feeling 2 pops, which represented the fascia lata and the fascia iliaca, and then putting a reasonably high volume of local anesthetic into this space. Whilst this block was traditionally unblind, there are now ultrasound guided ways of doing this. And doing this can relatively consistently block the femoral nerve and the lateral cutaneous nerve of the thigh. Some authors claim that you can get spread to get the obturator nerve as well, but that's probably a little optimistic. So there are a few more contemporary blocks that are being done. There's a suprainguinal fascia iliaca block, which is sort of an obligate ultrasound guided block. And this targets an area above the inguinal ligament where the lateral cutaneous nerve of the thigh, the femoral nerve, and the obturator nerve are closest together. And so you may be more likely to block all 3 nerves blocking at that point. It does have a degree of motor block associated with it. A direct femoral nerve block under ultrasound guidance can be performed. That's unlikely to block the lateral cutaneous nerve of the thigh and the obturator nerve. It may have some benefit in patients for whom quad spasm is a particular component of their pain, but because it has that benefit, it's likely to cause a motor block depending on the local anesthetic that's used. Finally, the new kid on the block is the PENG block, and PENG stands for pericapsular nerve group block, but it's also the surname of one of the authors in the initial paper, so it's kind of a play on words there. The PENG block targets the nerves that supply the anterior capsule of the hip, where the majority of nociceptive nerves exist. It's associated with a minimal motor block, and it should be quite straightforward to do, blocking between bone and the psoas tendon. The one downside of this block is that it's unlikely to hit the lateral cutaneous nerve of the thigh. So if you were going to use this block for a post-surgical block, you'd need to specifically target the lateral cutaneous nerve of the thigh separately. So we've already been through these reasons to delay hip fracture surgery. Nice. I think we can reframe this as a group of factors that we need to consider and optimize early. I won't go through them all, but I am going to talk a little bit about anticoagulants. The paper that's listed at the bottom here are the guidelines for the management of hip fractures from 2020 from the Association of Anaesthetists in the UK. And I think they split these into 4 very nice risks. So the risk of surgical bleeding, neuraxial bleeding, the risk of actually withdrawing the DOACs in the first place, and the risks of delaying surgery. And I think defining the balance between these things is important. In this paper, they stated that patients who were on DOACs did not have with hip fracture and going on to surgery, did not have an increase in mortality, but did have more bleeding and more transfusion. From a neuraxial point of view, the risk of bleeding associated with spinal anesthesia, well, the NAP3 audit of anesthesia practice in the UK said that with spinal anesthesia, the risk of hemorrhage, neuraxial hemorrhage, was about 1 in 120,000. It's very small, but that's not a number that takes into account the use of anticoagulants. So that would be in non-anticoagulated patients. In the UK literature, there is a push to be more and more liberal with the provision of spinal anesthesia on patients who are on antiplatelet agents. For example, patients who have a single antiplatelet agent on board might be offered spinal anesthesia if the risk-benefit ratio was deemed appropriate. And I don't think many people in Australia would be providing spinal anesthesia to patients on clopidogrel at the moment. Of course, stopping these drugs comes with its own risk, and that risk is predominantly of thromboembolic disorder. That could be the risk of withdrawal, the risk of stroke, or potentially the risk of DVT-PE. But of course, delaying surgery also has risks, and we've discussed those, and they're the worst outcomes. So fasting is probably a place where there's been a big change. So the traditional model of fasting was, nil by mouth, fast from midnight. I think orthopedic people like that because it's only 7 letters you have to write in the chart. So that was, fasting for 6 hours from solids and liquids. The current ANZCA guidelines that are out there are that you should fast for 6 hours from solids, and you should be allowed to drink clear fluids until 2 hours prior to the surgery. But we've already mentioned the SIP-till-SEND program today. Chris mentioned it earlier. And the SIP-till-SEND program suggests that whilst we should still fast from solids for at least 6 hours, patients should be allowed to drink clear fluids until the time they're called to the operating theatre. And this is particularly important in the group of patients who have hip fracture, who are unlikely to have a programmed time to arrive in the operating room, and often get bumped potentially by more urgent cases. So I think this is a program that you'll see becoming more and more frequent, and I think it's going to probably rely on individual institutional policy at first before we see it in more broad policies from national bodies. Just to get onto this point, what is a clear fluid? Well, water, clear apple juice, and there are a range of carbohydrate-containing energy drinks that are used predominantly as part of preparation for surgery programs. Vodka is a clear fluid technically, but I wouldn't encourage any patients or suggest that any patient drink vodka in leading up to their surgery. And you can get caught out with like cloudy apple juice or expensive posh apple juice, and orange juice with bits in is a no-go too. Interestingly, in the English guidelines, you're allowed tea or coffee with a little bit of milk, which is very English, and that hasn't made it into the Australian guidelines as yet. So practically, I think it's probably easiest to limit consumption to water, especially in elective preoperative group who are self-managing. I think carbohydrate is likely to be of benefit, and that's been shown in ERAS programs. And the recommendation for most people is about 150 to 200 mils per hour as a maximum amount of fluid. And the instruction I give patients is that if you're thirsty, you can drink water or apple juice until the time you come to the operating theatre. So onto the type of anaesthesia that we offer patients. I think many anaesthetists would have liked to have thought that spinal anaesthesia was the gold standard here, but study after study and meta-analysis after meta-analysis has been unable to demonstrate that that's the case. And it seems that either general anaesthesia or spinal anaesthesia is appropriate for hip fracture patients. And that's, of course, pretty critical when you're considering whether a patient's anticoagulant status with regard to anaesthesia. So anticoagulation should never hold up the anaesthetic, or there'd be very few times when it holds up the anaesthetic side of the equation if the surgeons are happy to progress. In the literature, it suggests that standardization of your anaesthetic approach in your institution is important. And of course, just doing things really well, including blood pressure control intraoperatively, is probably critical. So in conclusion, as you've heard from all the speakers this evening, there's a push to get complex patients to the operating room as quickly as possible. And that, of course, entails a balance between the risk of waiting and the risk of progressing. When it comes to fasting and anticoagulation, I think the question we always have to ask ourselves is, are we pushing the limits of what's sensible here? And with preparation and planning, are we taking too much of a cookie cutter approach, and are we making any sacrifice to individual care? So hopefully I've flown through that quickly enough to left you with some questions that we can address in a bit of time for discussion.
Thanks very much, Ben. I think if people do want to post questions, it's the Q&A box at the bottom of the screen. Please put something in. Currently, there are no questions, but I won't let you get away that easily, even though it is 7 o'clock now. We started a bit late, so I think we can ask a few questions. The thing that stood out for me from the registry data is the nearly 10% mortality rate in Victoria, which is higher than any other state. Why do you think that is the case?
Well,
Surgeons
want
in
to make it
Queensland are better. Sorry, Raf, you go.
well, first of all, I think that hopefully the data is not quite correct with the incomplete data. I suspect that there's still at least 25%, 30% of patients not being entered. But if it is true, I don't have an answer to it. You know, I would have thought that all the age and risk factors, all the patient factors would be equal across the different states. I don't think that in terms of time to surgery, we are particularly slow in Victoria. I don't have the data off the top of my head. Chris, do you know?
No, I think you're actually not too bad. Yeah.
So short answer is that we don't know until we got better data.
Another interesting comment is around supervision, and I think Victoria has very good consultant supervision of operating, whereas other states have less so, and that's been shown up in the Queensland Get It Right First Time audits. So yeah, that's interesting as well, but that doesn't explain the finding. I think it's small numbers and it's small differences, so it may not even be statistically significant.
Fair enough. A question here for Asanka. Delirium screen. Does Alfred just use 4AT for screening and diagnosis, or 3D CAM is also used as secondary confirmation? Which is always a goop to me, I'm afraid. But
no, so yeah, so we do use the 4AT for screening and for diagnosis, but all of our hip fracture patients are also seen by an orthogeriatric service. So I guess you get the second confirmation of expertise from a geriatrician review, and then informant history usually from family members. But we found that it was the easiest for the nursing staff to administer, and it really was the easiest tool for them to use in the ED to screen and then diagnose. So we don't go on to do the 3D CAM, but all of our hip fractures are seen by a geriatrics team. So I guess they become the confirmatory body.
And is there any sort of consistency about using something like the Nottingham hip fracture scale? You know, with say emergent laparotomies, we've got a ELAS score which people can look at straight away. But is this just done ad hoc, or is there any push to sort of encourage everyone to go through this?
So from our perspective in our health service, it is just ad hoc. I guess we tend to use the CFS more to kind of gauge how high risk, how frail a patient is. I like the Nottingham hip fracture score, so I will calculate it, but it's not sort of designated as part of our review of a hip fracture patient in ED. I'm not sure if other health services do different. I haven't heard of it, but I just like it as a tool, but it's not standardised for all of our hip fracture patients.
Yeah, I think we're still struggling to get anyone to ask any questions out there. One for Chris. How do we get all of the hospitals contributing to the registry? Because it is a really, really good resource and it changes practice. We all know this, and you collect fantastic data. But it's disappointing that there's, 20-30% of hospitals not contributing.
Yeah, look, it is disappointing, and it's something that we're trying to address. I do see that our registry manager is online, and she may like to comment on this. I think publicly, where resourcing is available, there's probably it's hard to justify an excuse not to contribute. Privately, I can see there's going to be barriers with funding and who does it and how do we resource this. But equally, there are private hospitals around Australia who are contributing as well, and that's fantastic. And one of our priorities, sort of this year and moving forward, is to try and increase the number of private hospitals in Australia that contribute, possibly to sort of stimulate a bit of cross-stitch rivalry. New Zealand has 100% hospital involvement, so hopefully that might help with the Victorians listening to go, we've got to beat the New Zealanders. Not beat people.
Ben, you got your hand up?
Yeah, thanks. I've got a question for the surgeons, if you don't mind me being a little impertinent. If you have a patient that's clearly palliative, rather than someone who looks like they're going to go on to have a really significant functional outcome, how do you change your operative approach?
Raf, do you want to take that one first?
So just to clarify your question, you mean that they're not going to die in a short period of time, but you're just doing it for pain relief. Is that what you're saying?
Yeah. So let's say you've got a non-ambulant patient, right, who you're just providing an operation for palliative care reasons, to provide them the best analgesic and to give them dignity in the last days of their life.
There are some instances where you would be able to change your surgical approach to make this operation quicker, but depending on the type of fracture, and there's some fracture type that you just have to do one thing and one thing only. So for those, for example, there are say subcapital fracture that you would sometimes do a hemiarthroplasty, but in a really sick patient, you might just try and reduce it and make a small hole and put some screws in just to hold it in place so that it will just hang on for a few days or a couple of weeks. So yes, in some instance we will and we can, but in other instances, if it is a displaced intertrochanteric, well, even then there are some variations you could do. Some people think that doing a short nail in those circumstances will reduce pain as compared to a DHS. And certainly a smaller cut. So yeah, there are some circumstances where you can vary your approach. Chris, what do you think?
Yeah, I was going to make the same point. Typically with a subcapital fracture, our concern in the longer term is the hip developing avascular necrosis and the patient needing further surgery, which is obviously not in the best interest of an elderly patient, which is why we do the hemiarthroplasty. But in someone who's either not going to walk ever again or not going to live long enough to develop avascular necrosis, I think just forming a 1 centimetre or 1 inch incision, putting a couple of cannulated screws in, like Raf says, very, very reasonable. Question to the orthopaedic team: how often do we do a Girdleston's procedure as a palliative procedure? So for those who aren't aware, Girdleston's is where you remove the femoral head, plus or minus interpose the gluteus medius muscle in between the femur and the acetabulum. It's a good pain relieving procedure. The problem with the Girdlestons is it's a reasonably invasive procedure still. It's the approach to a hemiarthroplasty, whereas what Raf's describing is a 1-inch incision with very minimal blood loss that you can pretty much even do under local anaesthetic, whereas the Girdleston's a full hip approach. I can't remember one that I've gone in deliberately. I've bailed out a couple of times where the patient's, been peri-arrest and I haven't put the implant in. So I suppose I've done a Girdleston's procedure, but I can't think of a scenario in a neck of femur fracture where I've gone in with that being my operative plan. I've done it in other circumstances. Raf, do you have any further comments?
Yeah, I think so I agree. Girdleston is a very invasive procedure. If you're trying to minimize the trauma, surgical trauma, you wouldn't do that. And I don't remember the last time I did it for a hip fracture. If it is so, if they are so unfit to have an operation, then Girdleston would not be something that I would tackle. I have a question for Hass. You were talking about nutritional assessment, and you said that there's like standard of who gets a formal assessment. So who does the screening? Do nursing staff do it, or who does that?
So at our health service, we do it. The orthogeriatrics team do it. So we've chosen the M&A short form because we found so it's a questionnaire that asks about weight loss in the last few months, concerns about nutrition, acute illness. We found it pretty easy to get either from the patient themselves or from family members, and then we can use that to refer to the dietetics service. We did discuss whether every one of our hip fracture patients could be seen by a dietitian. It just was not possible logistically. So we have had to do the screening ourselves and document it, and then get dietitian involvement. So it's us. So far, it's not nursing driven. I know that in some of the rehab and GEM units, they'll use a must score and other nutritional screening on their admission. But so far in the acute service, it's just time-wise, it's too much for the nursing staff to do that in addition to everything else they have to do. So we do it as part of our ortho-geri's assessment.
Thank you.
The question for Ben, is there evidence for facilities to do regional nerve catheter instead of just single shot nerve blocks in the ED?
I'm not clearly not sure of the evidence. Most of the blocks get done by emergency physicians, and I think they're just more comfortable with doing non-catheter techniques, and also perhaps lack the sterility to do catheter techniques repetitively. Especially if you're going to be if patients are going to be waiting up to 36 hours for their surgery, I think they're going to be much better off with catheters than they are with single shot block, which is only likely to give them 8 hours of analgesia at best. So I think there probably is a role for patients having catheters put in. Perhaps they could go from the ED via the operating room to the ward.
Great. And there's a question for everybody from Linda Ferris, who seems to be in South Australia, saying that NOFs are put as 0 to 24 and we get bumped repeatedly, and it needs to seem happy for them to be put off. How do your hospitals manage the priority?
Well, I suppose if I could go first, I think I've sort of partly tried to explain what we do in Toowoomba. We have a sort of a non-written policy that we try to avoid doing neck and femur fracture surgery after hours, because we feel that's not in the best interests of the patient or the teams. So if we're getting to day 1 post-injury, we up-categorize to what we call a category B. I'm not sure what your category would be, but we aim to do that within 4 hours. Now, a lot of our non-orthopedic colleagues kind of roll their eyes at us, but in Queensland, we are we're actually penalised 20% of our WOW, our funding, if we don't get surgery done within the 48-hour time frame. I don't know if that will now apply to the 36-hour time frame. So there's actually a hospital sort of push to do this as well. And I think if you get everyone on board with that, then that helps. We have a NOF working group in our hospital that includes a member of the executive, meets monthly to discuss our data and our performance, and we're looking at barriers, we're looking at things we're doing well, and we're always trying to improve. So as a health service, I'd probably encourage that and advocate for that. And you're going to have to come up with an individual sort of solution that works at your hospital.
I think that's where joining the HIP registry is fantastic, because you get live, constant stream of your own data in real time that you can use to show different stakeholders where you're meeting standards and where you're not. And if you're falling well below the 36 hours now, previously for us it was 48 hours, I think then you have the data to show the relevant stakeholders that this is an issue of concern that needs to be addressed, knowing what we do, the mortality effect for these patients if we delay surgery for them consistently.
Raf, any thoughts?
I have two questions, one for Ben, one for Chris. I'll start with Ben. We struggle with some high-risk hip fracture patients getting onto theatre when the assessing anaesthetic registrar or anaesthetist who go up and see them, at 3 p.m. says, yep, good to go, start at 6. And then the 6 p.m. anaesthetist will then see them and say, no, and we need a echocardiogram, we need serum rhubarb and all sorts of things. How do you have a system? How do you address that? I mean, is there a way of making this less of a problem?
It's a problem when anaesthetists all think separately, right? Because fortunately that problem doesn't afflict surgeons at all. So like one of the most useful things that ever got put up on a slide in front of me with the 7 things that should critically delay, that should be delays, and I think when you recognize that and you see that in the literature and that information is spread throughout your staff group, it's really helpful. So there's that. I think it's very important to recognize that no patient should wait for an echocardiogram. I think that's another excellent piece of information. And the third thing is communication within the hospital. So if you are the anaesthetist that's seen the patient, it's critically important that if you know someone else exhibiting the case and you know it's mildly controversial, you communicate with them to prevent this kind of thing that's happening. And time again, the answer to issues within the hospital system is good communication.
Thank you. Very sensible. Sorry, question to Chris. Regarding resources to collect the data for hip fracture registry, I think that a lot of institutions will confess, lack of funding as a reason for not joining. Previously, I'm under the impression that the hip fracture registry has got, a stash of business case or whatever to support that. Are you aware of that? Is Jamie there?
No, I'm sorry, I can't comment on that. Jamie's definitely online. She's typed a few responses.
Or Jackie. I haven't gone through the website.
Hi, Raf, can you hear me?
Yes.
There we go. Hi, Jamie.
Hi, everyone. Sorry, can you just repeat the last bit of your question?
Yeah, so is there somewhere a repository of like business case to apply for funding for someone to collect the hip fracture registry data?
We have had a few hospitals that have done so recently, and one in regional Victoria has been happy to share their business case. We haven't got a template for the registry insofar as for the collection and entering of data. I think there is a business case around a template around the orthogeriatric model of care for services that don't have a geriatrician or similar involved. But we can certainly look at whether we can share that more widely, because hospitals across Australia resource the data collection and entry very differently. And it certainly seems more common that specific funding is required in Victoria, where that isn't commonly the case in other states from what I understand. So happy to share the business case with you after this.
Yeah, great, thank you.
I suppose the other thing to say is, all hospitals are going need to be accredited, and this is a well-established national clinical care standard, and I think it's sort of probably with time going to get harder and harder to justify not being somehow assessing yourself against that clinical care standard, and I think participating in the registry is an excellent way of doing that.
I think there is some new money potentially coming for this sort of thing. I was reading today that the federal government is putting about 40 million into clinical registries. I'm not sure how it's going to be accessed, but they are very keen that more and more hospitals get involved in the whole gamut of registries. So there is a bit of hope out there. Is that your hand up, Chris?
Yeah, Philip, can I ask Ben a question, please? In New Zealand, the paramedics are putting nerve blocks in the field. What are your thoughts on that? And is that something we need to, or we should be considering in Australia?
I suspect that a well-placed nerve block is the best analgesia for a patient with a hip fracture. And there's a good deal of incident pain that would occur moving a patient from their bed to an ambulance trolley, from an ambulance trolley to an emergency trolley. So I can see clearly that there's that well-trained micro-level paramedics but should potentially have the skill set to be able to do this with the correct training. I can't really see why that shouldn't be an issue. Why that should be an issue.
Okay, Theo, who is our VASM orthopedic rep, has put a couple of points down there. Is it time to allocate dedicated theatre sessions every day exclusively for NOF patients?
I think each hospital needs to have their own policy. For somewhere like Prince Charles in Brisbane, where they're doing over 500 neck and femur fractures a year, absolutely. In Toowoomba, we do 180 a year. And we tried doing that, but then there are slots where, you don't have someone with a neck and femur fracture for whatever. So I think it depends a little bit on your volume, a little bit on your setup of your theatres, whether you've got dedicated orthopedic trauma lists, which would be helpful. You can slot neck and femur fractures in. For smaller hospitals that are dealing with, them less frequently, I think that's, you're going to have to come up with an individual approach that works for your hospital. And that's where having these, hip fracture working groups at your health service is helpful, I think.
Okay, and for Haz, he is basically saying he's agreeing with your approach for surgery for palliative relief, but questioning a Dutch study that shows little difference between surgery and non-operative management regarding a dignified death, and saying that the Dutch have led the way in euthanasia and palliation, and perhaps their results may not be reproduced elsewhere.
Yeah, so I would have to agree. So when I did read that study, and that's why I said it's from the Netherlands, they would probably be providing sort of a gold standard of palliative care. So whether that would be applicable to our local health services, I would have my doubts, which again is why I wasn't that influenced by that frail hip study, although it got a lot of airtime amongst my surgical friends. Because they are excellent at providing palliative care. And I think you would need very robust palliative care services that in-reach into nursing homes with highly trained nursing home staff for me to feel comfortable that a non-operative hip fracture patient would be managed well within our local nursing home facilities. I'm trying to be very politically correct about that. I don't want to offend anyone or anybody's specialties, but that would be my reservations, that a study done in the Netherlands would not be as yet applicable to our local health services and what we can provide in nursing homes.
Okay, and we'll make this the last question because we're coming up to 7:30 now. This is from Anne Williams to everybody. Back to theatre times. How do other hospitals manage high presentations of NOFs if you're getting a whole load coming in very quickly and trying to get them sorted out in a timely fashion?
There have been days where I've cancelled an entire day of elective operating and I've done 4 hip fractures in a row.
Yeah, I think cancelling electives is probably the obvious solution.
Would the bean counters be happy with that?
Well, if they're getting docked 20% of their wow if they don't get done within 36 hours, maybe. That's just a Queensland thing, though. I don't think other states have that.
Well, every state has different funding models, don't they? Which is part of the problem we face.
Is there interest from other states to pursue that kind of similar, I guess, negative enforcement for, or is that just a Queensland health type thing?
Can I ask, Jackie Close, are you able to make a quick comment? I know you were talking that there was talk of actually rewarding good behaviour rather than penalising bad behaviour, and that was at a Commonwealth level.
Yeah, but about a decade ago, the conversation was very much about how do you reward high quality care rather than penalise bad quality care. And most of us would be more incentivized by being rewarded for providing good care, and we just get pretty pissed off by losing money, and we lose interest if that's the approach. That conversation, so the interim report for the National Hospital Reforms has been published at the end of last year, and it does look like the conversation is starting up again about potentially rewarding high quality care. So the Hip Fracture Registry is very definitely interested in engaging with the relevant partners around that. There's evidence that it works in terms of the UK, where you provide a financial reward. It doesn't have to be necessarily a huge amount, but if you provide a financial reward, it is sufficient to drive quality improvement activity and ultimately then better outcomes for patients. So it's a topical issue right now. Whether this country ever moves to rewarding high quality care rather than penalising complications, I genuinely don't know, but from a hip fracture perspective, we absolutely are pushing for it.
Anne's also asking, is that any elective surgery or only orthopedic? Which I
Sorry, what was the
cutting
question?
into lists,
the cancelling elective surgery?
Yeah.
To do, oh no, I only cancel my own. Yeah. I'm not important enough to cancel other people's.
Obstetricians do that, yes. So, okay, well, thanks very much to all speakers. I think there was really, really good quality discussion there. I've learned a lot. I hope everyone on the webinar that was beamed in has learned quite a bit from it. It'll all be available on the website eventually, because someone is asking, can they use this? Yes, you can. I'd also like to thank the VASM staff for pulling it all together. We had a few teething problems with Zoom at the beginning, but it's worked out well. And I would encourage you to fill in the questionnaires and give us some feedback. And particularly if you want any particular subjects you want us to cover in the future, we'll happily do that in sort of depth as well. I think it's been great having an orthopedic session. I've really enjoyed it. We tend to just concentrate on general surgery a lot, so it's been a nice change. Have a great evening and catch you all soon.
Thanks, everyone. Good night.
Okay.